Daniel Campbell and Greg Wilson. They are the co-chairs of the Black African American Community Task Force, and we will go ahead and get started right now. Thank you.
Good morning.
Good morning.
My name is Greg Wilson. I'm a senior manager at In the Meantime Men's Group, a member of the Los Angeles County Commission on HIV, a co-chair of the Black African American Community Task Force of the Commission, and a proud co-facilitator of today's panel presentation. It is with my distinct pleasure to work alongside my co-facilitator for today's panel discussion, Ms. Danielle Campbell.
Good morning, everyone. After today's very illustrious vote, I think folks have a better indication of who I am as an advocate in this work, but I'm also research faculty at UCLA and at Charles Arger University of Medicine and Science. I too am a proud member of the LA County Commission on HIV and chair of the BAC alongside this lovely gentleman here, Mr. Greg Wilson, and we will facilitate today's commemorative discussion.
Last year, on February 14th...
before that, we wanted to thank everybody in the space for coming out today. We are so enamored with you all, and thank you for taking the time to make space for this very, very important discussion.
Yes. No, thank you. Last year, on February 14th of 2019, at the urging of Jeffrey King, the Commission convened a panel presentation for National Black HIV/AIDS Awareness Day, with various Black African American community stakeholders and HIV specialists to initiate a conversation and dialogue addressing the impact of HIV on the Black African American community. Immediately following that meeting, it was recommended that the Commission on HIV conduct a follow-up. On April 30th, a group of Black African American community stakeholders and commissioners participated in the first official Black African American Community Task Force meeting. A potent set of recommendations were developed and forwarded to the Commission's Executive Committee and ultimately to the full body of the Los Angeles Commission on HIV. Some of these recommendations have been adopted by various subcommittees while the Black African American Community Task Force continues to meet, forging a progressive agenda for 2020.
Indeed, we are. So just a quick point of reference. How many folks in the room don't know that HIV and AIDS in the world, and more specifically in LA County, grossly impacts Black or African American identified individuals? Raise your hand if you are unaware of this fact. Cool, so nobody raised their hand, so we're all in agreement that today's panel discussion is very appropriate. Yes, I don't see any nodding heads. Okay, thank you. So today, 1 year later, we are back here at the Commission to commemorate National Black HIV and AIDS Awareness Day and co-facilitate a panel presentation with a host of esteemed, highly esteemed Black or African American identified doctors, physicians, and HIV specialists. Before I take a moment to introduce those folks, if we could have a moment of silence to all of those individuals we've lost in this epidemic. Ashe. So, thank you. So I'll introduce our lovely panelists. To my direct right, we have, yes, you'll introduce yourselves. Yes, we're going to improvise.
Good morning, everyone. My name is William King. I'm an internal medicine doctor, HIV specialist, and serving in Los Angeles County, and I'm also a commissioner here.
Good morning, everyone. My name is Rochelle Rawls, and I differ from the rest of the panel because I am not a physician. I am a physician assistant, and I work at LA County USC at a facility some of you may know as 5P21, later changed to Rand Schrader, and I've been there for the last 27 years.
My name is Derek Butler. I'm a family physician and HIV specialist. I'm currently the Chief Medical Officer at the To Help Everyone Health and Wellness Centers. Many of you may know it as the THE Clinic from the days of old. I'm also faculty at Charles Drew University with the Pacific AIDS Education and Training Center, and co-PI with Jerry with the LAATC, and I am extremely excited to be here and hope we have a fantastic discussion.
Good morning, everyone.
Good morning.
My name is Dr. Condessa Curley. I am a family medicine board certified physician. I also have my master's in public health. I come to this table as a person who has done a lot of work in the HIV/AIDS field, both locally, nationally, and internationally. I'm currently the medical director of clinic services for the LA County Department of Public Health. And for full disclosure, I'm also a board member of the AIDS Healthcare Foundation.
So welcome, panelists. We are going to jump right in. What has been the personal experience or your personal impact of your presence as a provider in this work? And how do you balance practice, self-care, and humanity and service to individuals with so many unmet needs? For this question, we will start with Dr. Butler.
Thank you. I was quite surprised that they would ask a question about my own personal journey as an HIV provider in this community. Unfortunately, it was a little hard to answer it because I think I was focused mainly on what we were going to talk about as a group. But with some self-reflection, I really was able to really, I think, come to the realization for myself that being an HIV provider and it has really been, for me, I think, kind of the fulfillment of my goal of being a physician. And now I'm going way back because I'm one of the people who went into medicine for what they call the right reasons. You know, I don't think anybody in HIV is getting rich, but I think the richness comes from the satisfaction, the work you do, and the impact you have on your patients. And I feel like I'm blessed to be in a career that I can, you know, crawl out of bed every morning actually and happy to go to work, despite some of those stressors we all deal with in our facilities. But the work we do on the ground with patients is I think worth all of it. And I feel like for me, I started my medical education, my journey in medicine as a medical student at UC San Francisco in the early 1990s. And many of you have heard me speak, have heard me talk about this idea that, you know, my medical education was an HIV education. I mean, we saw patients every day who were, in those days, mostly dying of AIDS as I learned the art of medicine. And that stuck with me. I developed a really high level of compassion for those patients and a real comfort level with HIV as a condition, and really understood, I think, those outside of just the medical piece of it, but then understanding that issues of stigma, homophobia, all those social determinants that, you know, we still struggle with now. And in my journey, once I came to Los Angeles after residency, and an intention of mine being in medicine was to do something that I felt would be impactful for the African American community. Because where I grew up, there were no African American, there was one African American doctor for, you know, a whole neighborhood of people. And I felt this was part of what I needed to do. And now finding something that I felt I could be impactful for that impacts African American individuals was important. And I think naturally just coming to LA, my first job was at the Watts Health Center, and actually seeing what I think at that time many people I think still didn't really quite understand what was happening in communities of color in HIV in the 90s. It was still focused as a, you know, something exclusively in the kind of the white gay male community, but seeing what was happening when we were getting patients at Jordan Down and Nickerson Gardens testing positive every week or two. And I remember my first 2 weeks at Watts having a patient come in, a pregnant woman, African-American woman pregnant 20 weeks with twins who had come into our clinic, and the previous doctor was some older gentleman, OBGYN, who brought the security guard into the room to give her her HIV results at the same time. And the poor woman freaked out and ran out of the clinic. And of course, I show up 2 weeks later, and the nurse manager says, well, Dr. Butler, you know, you need to put a big chart down. This is when we had charts, not computers, in front of me. And it says, good luck with this. We need you to handle this. And of course, this woman, this is your classic case of social determinants, was homeless, living in her car, you know, no phone, pregnant with 20 weeks pregnant with twins and HIV positive. And this was 2000 in South Los Angeles. Now, happy ending, we found her, got her into care at USC, perinatal clinic. She delivered her twins negative. But for me, it was a lesson. It was really just a kind of like, I think this is what I need to be doing. And it kind of sparked a lot of my drive. As I was doing primary care and started, you know, focusing on testing folks in this community in South Los Angeles, and, you know, within 2 or 3 years, myself became an HIV specialist, treating patients, and really haven't looked back, because I feel like this, having seen this journey as a medical student in the early 90s through the era of art in the mid-90s to the 2000s, where we're now actually turning the tide. All of you graybeards like myself know that story. And to this day now, where we have single tablet regimens that if people can stay on them and stay in care, will do fine. And so it's evolved to this idea of, and again, I don't want to feel like I'm pumping myself up, but I feel like when I'm with patients, and that's where I think I get the biggest joy, is being that beacon of hope and truth, because especially in the African American community, and I focus there because African Americans, just in general, outside of HIV, in this country, I think really live in a world of you know, many times under excess stress, paranoia, hypervigilance about just being black in this country. And then when you throw on being black and gay in this country, and now if you throw on being black, gay, and HIV positive, you know, you could imagine the amount of trauma that person is probably dealing with. And for me to come in now actually, for me, make a difference, because a lot of times I love seeing newly diagnosed patients because I can have a real conversation. I tell them, I call it just I'm going to clear out your brain right now. Let's start over. I'm going to take a fire hose to your brain about everything you thought you knew about HIV, that you heard out in the community. I'm going to tell you the truth. And I feel like I'm legitimate in doing that because I look like that person and I can speak to them because I already understand in the African American community what people are thinking. I understand the myths, the ignorance, the stigma we have in the African American community, some of the issues around homophobia, disclosure, et cetera, that keeps many people closeted, that keeps many people ashamed, and what I call that self-stigmatize themselves. Like you did something wrong when all you did was you trusted somebody to have sex with unprotected. Is that really a crime?
Not so much.
Our politicians do that. People do that all the time. But that's not your fault. Like, again, you made a mistake like anyone, but we can do something about it. So let's get rid of that baggage. Let's get you empowered to take care of yourself. Teach someone to love themselves so they can take care of themselves and not be decimated by this disease, by this condition. I take that simple philosophy into every patient I deal with. And for me, and again, talk about this presence, this impact it's had. For me, it's a very powerful tool to be able to do that in this condition. It's hard to do that with diabetes and hypertension, which people kind of, sometimes don't take as seriously. But this one, many times, I think individuals come in afraid, fearful, terrorized by it. And if you can dissuade that and let them know that, and continue to support them in that they can be successful, live a whole, full, fulfilling life, and despite being black, gay, HIV positive, or black and poor, let's not forget poverty is another stigmatizing characteristic that most of my patients, unfortunately, are strapped with, that this doesn't have to be their issue. I can empower them for that, and they know they have support for that. So for me, I mean, that personally has been the satisfaction I have of doing work as a physician in this space. I think for me personally, I've always been someone who supports the underdog. I feel like I was an underdog growing up. I mean, I grew up poor with a single mother and was able to have opportunities to get to this point and level in my life. So I always have a soft spot for the underdog. And for me, a society that puts people with HIV already as an underdog, someone who may not be of the majority color as an underdog, that's already know that experience. And again, being gay or same gender loving, also in those spaces, for me, it's again, joy to fight for those folks, because I was one of those. So that personal connection, I think, for me, has been that satisfaction. And I know, I mean, in fact, my colleague, Dr. King, has published studies about how that if the provider of someone with HIV looks like them, and culturally shares a similar background with them, they can have better quality of care. I'm not saying in terms of medically, I don't think it's just the medical piece. Anybody can reduce viral load in somebody, but I think it's that bigger piece of care and quality that the patient is getting, and they take out of that visit.
Thank you, Dr. B. You made some really great points, one of which I think can facilitate us into the next question. You rather appropriately spoke about some of the social determinants of health. So we want to know if you believe that the public health infrastructure as it exists meaningfully addresses the social determinants of health that often adversely impact the Black people that you referenced, who are living with and or affected by HIV, right? We should be status neutral in some of these discussions. And if so, or if not, what tools do you believe you need to do your job better? And I'd like to start with asking Dr. Curley that question, and other panelists can also weigh in. What's missing, what you need? What do folks in the audience need to know about caring for Black folks?
Well, I'd like to first off and say that is a really loaded question.
Yes,
You know?
intentionally.
It is. And I work in SPA 6. That's where I initially joined. That's where I initially became a medical director in SPA 6. And, you know, as you look at a person of color, it's me. Sometimes we judge the book before we open it. And so that has always been my mission, to actually, you know, try to be at the table, and most of the times have been successful in really advocating for the people that look like me and the people that I serve. So with the question, first, you know, I said, how am I going to answer this question? I wanted to look at, well, what is the public health infrastructure? And the public health infrastructure, it sits on a three-pronged stool. And one of the stools is to provide a capable and qualified workforce. The second stool is to update, to have up-to-date data and an information system that can reply to any threats that we have. And then the third prong is that we be an agency that's capable of assessing and responding to both acute, which are emergency situations, and chronic ongoing threats to the nation's health. So then I said, okay, let's look at social determinants. How do we define that? And, you know, I sat back and I really thought about this, and the biggest social determinant that we as African Americans have is racism. It can be implicit, it can be explicit, but it's there. On a daily basis, I have to say my prayers before I go in. I put my coat of armor on to protect me, and I ask God, please help me to be a professional, to be friendly, to be open, to be understanding, and continue to be curious. That's what our public health employees have to deal with on a daily basis. And then there's microaggression that happens to all of us. So when you put those together and you ask me, are we meaningfully addressing the social determinants of health? My answer to you is, I believe that we are. 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 I I believe we are, but we have a long way to go if we start with racism. That's always the elephant in the room that we refuse to deal with, and that's key. We look at poverty. Yes, it is. We look at poverty. You know, we look at all the other social determinants of health that are upstream that stop us from getting downstream to the outcomes that we desire for everyone, especially those that are most marginalized. So, you know, that's huge. Is the public health department, public health infrastructure, is it meaningfully addressing? I think we're getting there. I think here in LA County, we have a health equity center. We have our employees that are constantly being trained on implicit bias, how we address that. But what we don't have really is a conversation that translate what we're being taught into action. I know that a lot of you have probably gone on and gotten your master's degree, and I remember when I was getting my master's in public health, I asked one of the doctors, I wanted to know how to do something. You gave me the theory, but how can I apply it? And I think that's what's missing. It's very difficult to sit down and talk to an African-American woman about compliance when she says, you didn't ask me what I need. And what I need is, I'm depressed, I'm sad. I can't even think about beginning to take my medications. I can't even get out of bed every day. And then when you sit back and you say, well, wow, what is it that I have? How can I help her? Where are my referral sources? You look at mental health issues that abound us. We look at the stigma and discrimination that you talked about, Dr. Butler. I mean, these are things that are not easy questions to answer, but we're aware and we're acknowledging, and that's what we're doing. That's the first step. And then it says, what support from the broader health infrastructure is missing? Dollars, funding. You know, I went back and I looked and I said, wow, the current administration has cut health professional training by $450 million. For the HIV and the epidemic, they've added $71 million. Do you think that's enough? Is it really?
No.
It is not. And then what tools do you need to do a better job? We need the funding so that we can train our providers, our community workers, our health educators on how we can be culturally aware. No one is culturally competent as far as I am concerned. We are not. That's on a road to where we should try to get to. But cultural awareness, how do I sit down and talk to a woman who may come in dressed with shorts, maybe with her breast, you know, tattooed up? I'm so busy looking at her, yet and still I'm not listening to what she's asking me, what her needs are, right? So we need the tools to be able to deal with that. We need the tools to be able to say to a woman who has come out and said, you know, my partner just got out of jail, and right now he's doing behaviors sexually that we didn't used to do. How do we address that? We kind of shy away from those questions. These are needs that, you know, our patients are asking us for, but yet and still we're not prepared to answer them. So I would say, give us the funding so that we can be prepared to answer them. Thank you.
Thank you, Dr. Curley. Ms. Ross? The bottom.
Yeah.
Yeah.
Thank you. I'd like to piggyback on that. I stand on the shoulders of a gentleman who was an integral part of this committee, of an integral part of this community. He brought me in at a time where I did not understand exactly what was before me, but he gave me that confidence that I could do this job. His name was Elliot Johnson, and some of you know him. His name is not mentioned enough, but he was an integral part in this community, and I loved him dearly. He has since transitioned. However, prior to him dying, I had a conversation with him, and he said to me, he said, Rochelle, please don't let that dream die. And so in answering, and he spent countless hours, and if anyone knew him, you would know how much time and how important this epidemic was to him. So I had to piggyback on this particular question because the face of our clinic has changed. When I came in 1993, I would leave on Friday and 2 or 3 of my patients on Monday had expired. I mean, it was amazing, some of the things that I had to encounter as I had been a physician assistant for 5 years, and I had spent 5 years working with methadone patients. So to step into this community that I really did not understand was extremely traumatic, to see people dying just day after day after day. However, here we are in 2020, and the bulk of our patients are not HIV and AIDS. The bulk of our patients are now primary care. And so as a result of what no longer exists, and what that means is the advocacy, the people that will speak up, the people who are not afraid to tell the story in relationship to the fact that there may be some retaliatory actions that occur. The powers that be have made the decision to now make this clinic more so a clinic that does not address the needs of HIV patients, AIDS patients, gay patients, women. Now we address issues that, and the bulk of the responsibility, mind you, is on the levels of the mid-levels. We are now under the umbrella, and I'm not trying to evoke any type of emotion. I'm just trying to tell you the story.
What do mid-levels mean for those in the room who don't know?
You have you have physicians, you have mid-levels being nurse practitioners, physician assistants, and you have nurses. So we're sandwiched in the middle, but you know the middle is where all the strength is. That's what I always say. So here we are. We were told, it's kind of like, and I'm gonna try to be as brief. I said, how do I make the people understand how difficult this is for us at this time? We have always been disproportionately affected by this condition, but here we are. Let's just say, for instance, you worked at a place where you flipped burgers, and then all of a sudden they come in and tell you, you know what, today things are changing. You're gonna now make cakes. How do you do that? We don't know how to make cakes. Well, we know how to do is flip burgers. Get it done. Oh. So I say all that to say, our infrastructure as it relates to Rand Schrader 5P21, as you all know it, has drastically changed. And the focus is no longer on the HIV and AIDS patients. It is now focused on revenue and what brings that in.
Good point. Can I make a quick one?
Absolutely.
Just, and again, I would like to add, just on a broader sense, public health infrastructure, because when you talk about social determinants, remember, health doesn't just, social determinants aren't caused by the health of the disease, they're caused by society. So what I see that what needs to happen is the public health community must get involved with the policies and the politics that set the laws that determine social determinants. Now, what I mean, for example, criminal justice reform, which we know disproportionately affects the African American community. And many of you probably who know that can affect these issues around HIV incidents, risk, etc. How do we put a public health message to our politicians to change that system? Some things are happening in certain places. We know now they're actually going to be, I guess, rescinding marijuana convictions in California now for folks who had felony marijuana convictions going back decades. And what that can do to a community where people are walking around and have to check that box to get a job, now opportunity is changing. Self-worth changes, the ability to take care of your family changes, risk-taking changes, right? Those are things that public health, I think, can have a message of how these things can be affected by these changes. Sex education in schools, I would say, especially in places that are like in the South, for instance, who don't want to do sex education in the schools, and we see what that does. How do you get politicians to be bold and brave when you bring a message of public health to them? I don't think they get it. I think politicians just look at what the media, the popular thought is, and are seeking votes, but you have to get someone who's courageous enough to say how their policies and the politics can affect these social determinants, right? And of course, funding. I mean, obviously, they're going to make the decisions around funding and where that goes. But I'm saying there's a sphere and an influence public health can have. This commission, someone here can go to our county commission of politicians and tell them these are things we need to happen and change, not just about health, but about other things that affect our patients' lives. Do we have a voice in those decisions? Are we making it clear that these are extremely important too? And again, talking about, and looking again, STDs, again, we've already went through, I heard, earlier talking about the STD epidemic, which of course we know is tied. We'll never get rid of the HIV, we'll never stop the HIV epidemic until we deal with the STD epidemic, and they're intertwined and they have to go together. And that has to start also with our policies and our politics. We're a hypocritical country, I hate to say it. We're puritanical on the face, but everything else is going on. And as Tony Mills mentioned in London, England, I was trying to look at comparative issues. London, England is at 95, 95, 95 for their HIV epidemic.
They have a
You guys know what
centralized
that
healthcare
means?
system.
Right, they do. But there's also a attitude. There's policies and there's kind of a understanding among their populations to get these services, not hide from them. Because our issues about not being 99-90 aren't just about the resources. Some of it's about what we've taught our populations to believe and to understand, and behaviors around, I guess, stigma, as we talked about in social determinants, that keep people from accessing care that they could access if they had it. So public health needs to speak up and that's our role, I think, as an infrastructure, bringing data, information, and influence to the people who make the laws that also affect things outside of medicine.
Thank you. There's been a lot of discussions around ending the HIV epidemic. Given your sentiments on the reality of lives of the Black people you serve, what will be needed to end the HIV epidemic among Black people, the most impacted population in this epidemic? Are we premature or getting ahead of ourselves in our conversations around ending the epidemic? And for this question, I would like Dr. William King to start.
Good morning, everyone.
Good morning.
Good morning.
So, Greg, a quick answer to your question. I do not think we're premature. But my concern is that we're behind. Today, we've been hearing about RFAs, we've been hearing about funding sources. We're all concerned about that as well. However, what I think we need to do as a group, and I say we as African American providers, as social behaviorists, as community organizations, we need to pull our resources together. We need to be able to understand how the RFA process has worked. We need to share best practices, and we need to take our collective action to go to these commissioners, to go to the council individuals, who many are in a heated election right now, Dr. Butler. And we need to tell them what we need for these resources. Also, I want to go back a little bit to number one. I've known many of these providers here on the table for years and decades, and you will not be able to have a more committed providers than what you see here. But we also need your help as well, too. Many times, although we show these stories, there is this vicarious trauma that providers are seeing. How many of you have had a provider that's died in the last year or so? How many of you have had providers that recently retired as well, too? The hole that's being created by these deaths, by these retirements, is impacting our community directly. And that burden then falls more upon us as well. I'm sure they, as well as myself, we take our patients home with us. Our job doesn't end at 5 o'clock. It continues. We cry, we go to funerals. We write letters. We we try to figure out ways where the insurance system leaves these patients in a hole, and we try to fill it up as well. So we need your help to lift us up as well. In answering the epidemic, my concern is that I see it as the cascade as twofold. I think we do a good job in terms of testing. My concern is what happens with the clinical component, with the linkage to care, the retention of care. and the viral suppression. I think if we get somebody in clinics, right now, we can suppress them. We can suppress them easily. But we need your help in terms of helping us with the social structures that is needed, of doing warm handoffs. This is why I'm trying to reach out to various community organizations to do this case management that I cannot do within my own clinic. This is why I reach out to Dr. Butler. If there are patients that I cannot take because of insurance, or he cannot take because of insurance, we work together. Because our common goal is not necessarily to drive a Benz. Our common goal is creating quality education, quality care for our patients. And we have to do it by any means necessary, we will do it. The other thing I think we need to do is that I want to, like I recommended last year for the formation of the task force, I want to recommend DPH sponsor grant writing workshops for us. Because, as Dr. Ferreira said last time, it should not necessarily go to those who also write the best grant. There are many people, many organizations, three-letter organizations, who are now being overshadowed by the four-letter organizations. And I don't have to say their names out loud.
No,
Yeah.
we won't, no tea, no shade.
But these three-letter organizations, they need help and support through grant writing. They need to understand the language that is being looked upon as well. Because with the end of the epidemic, the money is coming already. We need to be able to answer those questions appropriately as well. So we're not surprised at the Project Empowerment Grant, RFA that came out a couple of weeks before we all had a holiday vacation.
And the results of which came out, what, a couple days ago?
And we weren't even notified.
Say it.
But if we collectively work together and realize that, yes, we'll be sharing a smaller pot of money, but the overall goal will be to protect our community. We need to start now in terms of recognizing that, because that's how we're going to get the funding. We need these grant writing workshops. The other thing we need to do is, I think that also is that HIV, although we talk about this endemic with STIs as well, I think of it more as a clinical. As a primary care provider, HIV specialist was doing this for 20 years. I think of this more as a clinical condition. It's a chronic condition. Just like we treat diabetes, treat hypertension, which is intertwined, I think, with HIV, because the metabolic conditions, cardiovascular conditions that can happen with the medication, but also with the illnesses as well. And medical model is very important. We can treat the STIs, because the STIs, a lot of times are one and done. HIV remains, but it can be suppressed and controlled. So those are my major considerations. I'd be loving to hear the rest of the comments that the panelists have to say.
And Dr. Curley's.
Thank you. Thank you, Dr. Butler, for giving us your insight about the Public Health Department. And I just want to say this. When we had Ebola, how many of you remember Ebola, right? I was on duty and I had to actually go and interview a patient that had direct contact. And when I went to the patient's house and I spoke with him, he said, "And where are you from?" And I said, "The Public Health Department." He said, "Well, I didn't know you guys did that." And so even with the coronavirus, with measles, the one thing that I think, if I'm going to constructively criticize the Public Health Department for which I work for, is that we're stealth. We don't let the public know what it is that we are doing. We have many times actually sat with politicians. We have a health equity center. For those of us that work in the Public Health Department and do the work, it's very hard work. We are asked for our input. Right now, we have coronavirus that we're all dealing with. But is that something that we actually put out there, that the work that we're doing, like being on call 24 hours? So what I would say is that, we talk about letting our public health, letting our politicians and our leaders and such, going to them and letting them know, giving them information or advocating, like us advocating for folks. I think that, we're stealth, and maybe that's what we need to do more of, is really let the public know how your taxpayer dollars, what they're doing in the community. So I'd really appreciate if you go away with that, just that one message. You know, I don't represent the public health department as I'm sitting here. You know, I represent myself as a taxpayer, as a physician. I do work for the public health department, and I do understand, you know, what it is that the men and women who work for the public health department do on a daily basis. Thank you.
Dr. Curley, along that lines, how can we as frontline providers interact better with the public health department, particularly the public health nurses? We are seeing TB, we are seeing syphilis, we are seeing these diseases. In the olden days, we used to have those public health nurses go out to the patients and help us with that. Now it's becoming incumbent upon us. How can we develop a better relationship with you and your team?
You know, we're always there 24/7. I think, you know, when you go back to the funding, and it's really sad to say, I was in a meeting and we were informed that we had to do more with less. And that was like a kick in my gut when I heard that. And you should have seen the face of the person who said that. It was like a kick in their gut. But that's what we're faced with, doing more with less. So, you know, Dr. King, I think, you know, it's about really collaborating. We can collaborate on a health center per health center basis geographically. But I think, you know, there are enough community task force meetings that are held at various places where, you know, I know in your busy day you're not able to do that, but maybe we should consider having it during a time when you're off and you're available to do that. So, you know, what I would say is that I would take back that, you know, we need to be more mindful of folks that work 9 to 5 and their inability to attend all those meetings where decisions are discussed. So that's one thing that I think we should be able to do.
Thank you all for your very insightful comments. I guess to press the discussion along, we've been talking about ending the epidemic, and I know anybody who works in public health, specifically within the realms of HIV, have heard these conversations about ending the epidemic. And a lot of us don't even know what it really means, right? We know that there's a ton of money coming. We don't know from where. We may speculate as to where these funds are coming from. There was a huge RFA that was released, I believe the week before last, from the CDC. But in terms of some of the practical applications of that RFA, when we talk about getting to the end of the epidemic, you can't talk about it without talking about PrEP, right? We are a part of a planning body, and PrEP is part of the seminal discussions that we have. So from a Black perspective, there's been a ton of push to get people at highest risk for HIV on PrEP. Like, we have to call that what it is. And in Black communities, there's been a variable uptake of PrEP amongst our folks. There are some thoughts, right? Some folks would speculate that monies used to support programming and infrastructure to get Black or African American people on PrEP don't make it into the coffers of agencies with the most well-documented service footprint in those communities. You've heard it as a recurring theme from the panelists today, and I'm sure folks in this audience can agree. RFAs come out, they don't always get funded in the agencies of individuals who do the most work in the most affected communities, and we don't always know why. So I'd like to ask the panelists specifically, what are their thoughts or recommendations on how we as advocates of the diaspora, what we can do to work with funding agencies to make this happen. And you all have received the copy of the Black or African American Task Force, our recommendations that we pulled together as a collective group of Black or African American identified folks. What are your thoughts on how we can better do this work to talk about PrEP with funding agencies or CBOs that may or may not be funded appropriately to increase awareness and uptake of PrEP? I mean, it's part of our LA County strategy as well, so I would be remiss if I didn't highlight the work that we as a commission in the county has done to get folks on PrEP.
No, okay. I would say a few points regarding that in PrEP. And again, as you mentioned, I think all of us are aware, the uptake in the African American community and the communities of color in general have been extremely low. My own anecdote, I was in Alabama last month, and I was working there. I spoke to some folks who were in the PrEP kind of world there, and they said almost like 90% of the gay white males are on PrEP. They're like, oh, I'm already on PrEP, and there's probably the opposite, 10 to 15% of the African American gay population, MSM, are on PrEP there. But focus back here in Los Angeles, how do we get funders to improve those rates? I mean, again, that's something I think all of us struggle with. All of us who are at agencies who are doing PrEP, how do we get how the funding that we have, how do we use it effectively to make a difference to get African Americans on PrEP? I just would counter that. I think we need to step back and look at how our approach to bringing PrEP to this community differently, because we have to understand that the stigma on HIV is already the biggest elephant in the room I see in the African American community, and homophobia. So I think funding has to, in my opinion, has to get out of the HIV space all the time, because we give money to the groups that are treating HIV. Now we're going to branch out and do PrEP. But remember, those are, why aren't we looking at other communities serving African American, other organizations that aren't just HIV focused serving the African American community? Groups, I would say, like the NMA, groups like, the sororities and fraternities, folks like Planned Parenthood, who do a lot of women's health care in the African American community that's not just HIV focused. Are there grants available to, again, non-HIV providers? They don't have this long resume of what they've done in the HIV treatment world, and getting the footprint in those other organizations that can bring PrEP. Because again, as a primary care provider, I see, seeing patients, PrEP isn't useful in an HIV clinic, right? PrEP is useful in a primary care clinic.
Yes.
Right, where people are recognizing someone at risk or treating STDs and STIs. So how do we get the funding to those places? And again, in the African American community, you see the 4-letter words and the 3-letter words. A lot of African Americans I'm not going there. People are going to think I have that, right? I mean, there has to be a way to give an image and a message that's not in that space. And you have to have people from that community who can communicate the message and the benefits of PrEP to them. I was just reading, I think many of you may know Dr. Ronald Brooks at UCLA, but he's doing a study, the LA PrEP Stories Project. I don't know if you're familiar with this project. And one of the comments is just looking at people on PrEP, especially African American, and see what's their attitudes, what are their trends, et cetera. But the idea of the power of knowing someone else on PrEP who looks like you is huge to get people to continue and to expand that service. So how, again, organizations that can bring that message that I think in a non-stigmatizing way, because I don't think we can fix the stigma of HIV in America overnight. That's a long process. I would ask Magic or somebody else to come forward and really say, hey, HIV, I got it. Unfortunately, as an African American, I know we follow things that are passionate for us. The African American community, the biggest movements we have as African American community happen when we happens with us. It doesn't come from above. The civil rights movement started with African Americans coming together, finding a plan and a way to fight to change what was going on in society. That has to happen, I think, in HIV. So where do you start? You start with organizations that have that pulse. HBCUs, the Urban League, the NMA. Black doctors in primary care treat black patients. I speak at the NMA conference every year, trying to get, my colleagues to get this attitude of, normalizing HIV prevention. Testing is something normal you do. It's part of care. And, bring that to the patients that you're serving. I always say, too, the presence and, again, normalizing HIV. I always talk about the AIDS walk. Well, the AIDS walk goes from, West Hollywood to Beverly Hills. The AIDS walk doesn't walk down Crenshaw, right? Why don't we bring that presence? So, for me, and again, I'm just saying how powerful it is for, maybe people with HIV advocacy in the black community walking down through the black community, showing people in the community, hey, we're doing okay. This is what we're trying to do. You can be involved in this. You need to be aware. See what I'm saying? So I think funding for PrEP, I think we have to rethink it. We have to think out of the box. You know, HIV started as something we had to treat out of the box. All of you graybeards like me know, you know, the things you had to do, getting medicine approved by FDA before it was even tested in mice. You know, we were doing that to save patients' lives. We thought out of the box to respond to the disease. Let's talk about now, let's respond to really ending the epidemic in communities that are most impacted. And again, I'll say black churches too, I'll throw that out there too. I don't know any pastor doesn't like money, right? So let's look at, can we partner with them in a way with a progressive place? And again, using public funds, I don't know. I mean, that's, again, it takes thinking out of the box to address this, because people, black people, they go to church and they listen to their pastor, right? If you find that right one, you got to find the right one, of course. Who's not going to buy a Cadillac, but who's going to actually use it. But I'm saying, I'm just kidding, I'm sorry. But I think you get the idea of what I'm saying. And I'm sorry for not being so eloquent, but I'm just speaking out of passion and just thought about how we can do something. We can't just stay in the HIV space. Thank you.
I appreciate that. You know, I reviewed your recommendations and I thought, wow, what a great job. You guys did absolutely fabulous. And I think one thing that stuck with me was your recommendation number 11. And for those of you all that don't have that recommendation, it was to end the practice.
It's in their packets.
It's in your package. To end the practice of releasing requests for proposals that have narrowly defined proposers' minimum mandatory requirements. You know, I was just at a conference the other day, and a lot of people, like you say, they have great ideas about what they can do, how they can impact their communities. We talk about return on investment, but let's look at social return on investment. We talked about the barbershop project. Where's the salon project for women of color? You know, when you go down to the Essence Festival, and it was held in Louisiana, I think about maybe 2 years ago. And for those of you who don't know what the Essence Festival is, Essence is a magazine for black women, and it's huge, huge. They did a survey, and 80% of the black women had no idea what PrEP was. Now, if you know anything about Louisiana, that's the seat of the epidemic.
It is
that is a sin and a shame, right? So we're talking about, you know, why do they make the restrictions so restrictive? Open it up. You know, let's have people put social returns on investments as means of doing the work. You know, where do women go to congregate? Where do they talk? Well, you know, we go to our salons. I think our hairstylist is the best therapist, unpaid, that we all have as African American women. We have our sororities that we attend to. We have our churches, our missionaries. We have our schools, all these places where black women congregate and they talk. Where are we? Are we in that conversation? Are we teaching them how to actually talk to each other? Are we teaching them how to say, you know what, if that doctor treated you that way, treat them as if you were buying a pair of shoes and the shoes didn't fit. Would you buy that pair of shoes? No. You'd go out and get another one. So these are things that I think that we really need to look at. We really need to look at how this commission can really impact, and maybe public health can impact the way that these minimal mandatory requirements are written.
Thank you.
Also, lastly, where have you seen a billboard with women advertising PrEP for women? I've never seen a woman in a billboard advising her to get on PrEP. It's always two men.
Well, you know, back east, they're a lot more progressive. But here, there was a campaign, right? DHSP funded a very lovely campaign a couple years ago. It's a women for PrEP. But we don't have any billboards, though. But okay.
Just real quickly, because I know we want to get audience participation. One of the things we can also do, Dr. Butler, is we need to talk to our physicians, our providers as well. You know, I've been a past president of a chapter of the NMA, and let them know the nuts and bolts of PrEP. Not just the prescribing, but actually at the billing and the coding. And this is a primary care issue. Bless you as well. Salute. This is a primary care issue. and this could be easily treated within our community. The other thing that's happening is that it's being taken out of our hands now. The pharmacies will now be able to, in California, furnish it. We have to make good relationships with these local community pharmacies, because after they do that fill, those patients have to continue with us.
Yes.
We need to sign up at all the Please Prep Me, all the advertisements, all the things that we could do. But bottom line, again, is the idea of having our communities of providers and service organizations working together to deal with the nuts and bolts. Because I agree with you, it should not be within the HIV clinics. It should be within the communities, community physicians. And we know that African American consumers are looking for African American providers as well.
Thank you all for your lovely comments. So I think we've heard the words HIV in women discussed throughout this panel discussion, and I think it's a trigger for me, just being a woman and working and living and playing and earning an income in HIV and clinical related research. So those aren't two words that are often synonymous in when we do this work, right? So you don't always talk about HIV in women. Women get HIV and then that's it. They are siloed off to the left. And then when you think about women in HIV, you say, okay, well, let's talk to Dr. Spencer. So whether from a perspective of treatment or prevention, Black women are often omitted as part of this conversation, be it intentional or otherwise. So to the panel, we'll start with I'm just gonna call you Dr. Rawls, okay? Okay, well, what do you starting with Miss Rawls, okay?
No, you will not do that to me.
I want to say, what are your pronouns, but what is your affiliation? What is your professional affiliation, right?
No,
So what have been your experiences in serving Black women? What must we do to continue to include women in women-centered discussions as we get to the end of HIV? Because you can sit in a space like this, and we can go a whole day without talking about HIV in women.
Yeah, that's very true. And I actually went to Dr. Spencer because the truth of the matter is I do not have a lot of HIV women on my caseload. In days of old, I had more women, Black, Hispanic, but today those numbers have dwindled, and that speaks volumes to what we're talking about now. But she said to me, she said, Rochelle, just for me, just say, don't forget about the women. They are still grossly affected by this condition. And she wanted us to know that, again, PrEP was her big thing, and PrEP is not introduced to them. So I don't see a lot of HR women on my caseload, but again, we know that they are the last ones to be treated because of their multiple layers of issues. They have children, and now they even have parents they're caring for that are aging. So it's not even so much, the family dynamics. It's also now, how do I deal with my aging parents and still deal with my own conditions? So we have a lot of work to do as it relates to just dealing with women in HIV and AIDS, a lot.
We talk about HIV and AIDS. I think Sandra Rogers kind of brought this up. Let's look at the gateway to getting HIV and AIDS, or STIs. It's amazing in our community how many women come in and either, don't know their bodies, they don't have the power to say no, they don't have the power to negotiate condom use. They may be in situations where they're dependent upon their partner to take care of them or their child. There may be domestic violence involved. I mean, these are conversations that, a 15-minute visit just can't even begin to unravel. So when you talk about HIV, I think we need to talk about prevention first. And the prevention first is, you came here with an STI. And then we talked about the social determinants of health. What is it that you need? What is it that you need from me? And we need to train our providers to ask that question and to be sensitive to that question. There are many times when you'll go into the hospital, and I've worked in a few, and the patient will come in, and they will always look down, especially they're African American. They will have such reverence for doctors and healthcare providers that they're not able to express themselves. They don't know the language that we use, and sometimes we use the language intentionally or not. These women are not empowered. So what I would say that we need to do is we need to train as soon as someone comes in and they're African American, give them an advocate, somebody that's trained that can help them to negotiate the conversation, negotiate the system. You know, we hear of African American women who go in and they will say that they have a certain symptom, and the first thing that's put on there is that, oh, they're anxious, they're depressed. If we look at some of the data that says, you know, is this an MI that this person is having? If it's a Caucasian person, it'll be an MI. If it's an African American, the study shows, go home, relax, you're just anxious. So, you know, we really have to be cognizant of what the African American woman faces when they enter into the system. And, you know, HIV, unfortunately, is an end product. We got to start with our STIs. We got to start with asking people what they need, and we got to start with helping them to advocate for themselves or providing somebody that will advocate for them.
Thank you. Now, Dr. Curley, you know a little something about HIV in women, don't you? There was a conference that was held in Atlanta this past weekend that was focused exclusively on Black women in HIV.
Yes, it was. It was a powerful conference, and I think, you know,
What's it called?
It was called The Paradigm Shift, and it was about, it's a 2.0, African-American women and their families, and a call to action. So initially, you know, we called the meeting a conference, and then we said, no, it's not a conference, it's a summit. And the difference between the two is that with the summit, we're going to have a call to action. There's an action plan. It's just not us sitting down and talking at each other. It's about doing something. And so we're coming away with an action plan. We're also publishing some of our findings from our first conference. Thank you.
Thank you. Thank you so much for those responses. We wanted to make sure we had time to open up the floor for questions. So if there's any audience questions or comments, we are going to be taking them. Just bear with us. We see this hand first. So would you like to come state your question?
Is there a mic or we?
Oh, yes. So the mic is going to come to you. Yeah, you come up here. Come up here.
Good morning. My name is Charles McWells. I'm an HIV Prevention Services Manager, pardon me, with the Los Angeles Centers for Alcohol and Drug Abuse. Before I ask my question, I want to acknowledge someone who was here earlier, but I don't see him now. We're here today to commemorate National HIV/AIDS Awareness Day, and there was an individual here, a brother here, who almost single-handedly created the National Black HIV/AIDS Awareness Day movement here in Los Angeles, and his name is Richard Hamilton. Is he here still? Richard, would you stand up? I want to just acknowledge, because we don't do enough to acknowledge the work of individuals here. And Richard, thank you for everything you did beginning back in 2002. So Richard's an example of a black leader in this community who has done extraordinary work over many years to end the HIV epidemic among black people and others in this community. Healthcare providers also have a role that they can play in developing leadership, grassroots leadership. And so my question for you, providers, is what can you do to develop a new core of HIV leaders? A lot of us are graybeards. We're getting to that point where we're ready to sit down. And particularly among our young people in this community, there needs to be a concerted effort to empower them to take over the reins of power. What can you do as healthcare providers to make sure that that happens?
Great question, Mr. McWells. I think what I do, and I may have a little bit more freedom because I have a private clinic. So I've opened my clinic to medical students, to PA students, to nursing students, to introduce them to HIV care, to PrEP, to trans health as well too. So a lot of times now that once students hear about this opportunity in my clinic, we get a lot of calls to come and shadow and to learn. Because they don't get that at other clinics. They're not introduced to sexual health taking, not introduced to PrEP, and they're not introduced to the intricacies with regards to providing HIV care. That's one of the things we could do, is by providing opportunities for medical students, PA students, and nursing students. The other things we need to do is, as Dr. Butler and I both said, we need to go to our separate communities, our medical societies, our fraternities, our sororities, and let them know as well too. A lot of them not only need to be trained in terms of how to take care of patients, but they also may have sons and daughters who also want to become physicians. I open up my practice, anybody that wants to have somebody that knows wants interested in healthcare to come to my practice to learn.
All right, and my question is actually regarding trans men of color. Me being a FTM, I'm a trans man. You hear so many things about MSMs, black women, or even trans women. But as a black trans man, how do you even go about getting treatment when you are dealing with dysphoria? Because you have to deal, as a trans man, you have to look at PrEP on the form of a woman if you still have your female body parts, because PrEP may take longer to get to women. It's a lot of different things that are affected, but we have all these studies for MSMs and trans women, but what about black trans men, and how do we navigate dealing with dysphoria, dealing with going to a doctor who may get caught up on the way you look, like, oh, I didn't know, and like, you don't even get past that. They're so caught up on how good you pass that there's no type of information, no type of true care to deal with you even being open enough to be like, hey, so I hope I said that the right way, but that was my question.
Thank you.
Well, I would,
No, go.
well, and this, I think, ties into your question, too. Healthcare is expansive now. Unfortunately, you got to shop around, as you know, and I'm sure you have, to find a place where you feel comfortable, welcome, safe. You find your sanctuary. This ties into my comment about, I think, for the African American community, what I'm seeing in Los Angeles. When we see now, the gentrification that's happening in South LA, you're seeing populations, concentrations of African Americans are going to, next decade or two are probably going to be dispersing, as we see what's happening. So clinics that were traditionally treating many of them are going to probably have to evolve, as my patients move to Lancaster and Riverside or wherever they have to move to afford to live. My gauntlet out for all of you who are leaders in organizations that are involved with HIV care is, and I think you all know this, make sure your staff, you've seen this, has multicultural, multi-sexual orientation, gender identity folks on your staff, so that even if your clinic is out in Whittier, or I'm sorry, I'm not going to name a place, but I'm saying, but some of folks that are leaving their traditional communities may have to seek HIV services, prevention services, STD services at these other places. Try to make sure you have folks on the staff they can identify with, who can help them navigate. Because, again, it's always powerful to see somebody like you, at least okay, I know, okay, I'm going to be okay here. At least somebody here looks like me and can help answer my specific questions, will understand kind of what my fears and issues will be. And again, for the gentleman here, I would say, finding that place that knows trans patients, right? I hate to say it, not everybody, you can't cookie cut you can't just walk in any Kaiser and say, I'm trans, help me. No, you find a place that can treat you, right? And again, pledge all of us and that we make sure a commitment to our staff to make sure that piece is there, because it's important, especially in the epidemic in communities of color.
And Dr. King?
Just real quickly. So this came up last year with Lucky as well. And so one of the things that I had pledged to do was to train myself more with the issues of trans men. So I went to the UCSF Trans Health Conference and learned. I think that's what we could do as well, Dr. Butler. We can bring this issue into our medical societies. And maybe we're trying to see if we can work with Lucky and his group to try to get the training to do that.
And if you look in our recommendations, we have a special carve-out section for the need to address the health needs and desires of trans men specifically. So don't sleep. We see you.
So next we have Jeffrey I see Lewis, and then
Good morning. My name is Jeffrey King, and I'm with In the Meantime. And I want to commend our young excellence here for facilitating such an amazing panel. And I want to say thank you for bringing up Elliot Johnson. He was a friend until he closed his eyes. And he talked quite a bit about his experience in being a black man and running that clinic. So thank you so much for bringing that into the space. Our younger people could benefit from your experience and sharing the knowledge that you have, because there is a disconnect. And so as a result, we don't have that context for them to know that some of the stuff that they're talking about, we've done, it didn't work. And perhaps they can build upon what it is that you bring to the table. I'd like to thank those of you who have shown up to In the Meantime, you know, to be able to call you and you show up. You know, we have so many false prophets who have shown up in public health. Many of them look like us, but so many of them don't look like us. And what they do now is they bang on their chest and they taunt about what they're doing for underserved, marginalized, doubly marginalized communities of color. And they insult us as if we don't know what you are or are not doing in our community for our people. How dare you? What arrogance that you would dare do that. I worked for the center 20-something years ago, and I left that place as fast as I could. Because one of the things that was very clear, and has been very clear for many years, that our kids come to me and say, Jeff, those people are racist to me. They don't even speak to me as an individual doing this work in that space. We're afraid to show up today because there's an X on your back if you show up and dare to speak the truth. There are people who are opening facilities within South Los Angeles. I commend you for doing that. But will you actually do the work? Or will you show up at 0% goals met? How dare you do that? How dare you do that and then show up and bang on your chest and say, we're doing so much for you people? My question to you is, this panel, how do we better attract and retain qualified, passionate black physicians and medical staff into the HIV arena? What are the perks? What's needed to do that? Because we know so many physicians are actually leaving. But how, and with that exodus, how do we begin to attract that young excellence and brilliance that we need, that you spoke so eloquently about, that we need to see when we show up in our places of wellness?
Thank you, Jeffrey, for that question. You know, I do a lot of work in the community with a lot of community organizations that are interested in the STEM or STEAM program. And so what I find is that, you know, we set our targets on people going into the sciences and healthcare when they're in the 10th, 11th, or 12th grade. That's, I think, is too late. Also, what happens too is that people look at you, and if you look like them and they're very young, they know that, wow, I can someday be that. So to your question, I think not only mentorship is really key, even for those that are thinking about medicine when they're in undergrad, taking them on when they're working on their post-bac programs, which are programs where people have tried to get into medical school and haven't been able to do so, offering them the opportunity to do internships if we're in the position to do that. But I think more importantly, we really have to get into the elementary and junior high schools. I mean, that's really key. That's where people are most impressionable. That's when you go back and you ask the kids, you know, what do you need? Well, I had a professor, a counselor told me, no, you can't do that. You can't be that. Your grades aren't good enough. Well, why aren't your grades good enough? So we have to really get down to that level of granularity to actually look forward into the future. You know, for me, succession planning is huge, and it started day one for me. And so I would say that for all of us that are providers in this room, no matter a nurse, doctor, PA, radiology tech, whomever you are, that you got to think about succession planning when you first start and make that part of what you do. Thank you.
I would also just add, what are we doing? And thank you. It's starting with those professionals, health professionals. I mean, I'm part of the IPE program with the ATC, the interprofessional education, experience, I was going to say, education, where we actually take a team of a student from Charles Drew Nursing School, UCLA Medical School, USC School of Pharmacy. Now we have a psychiatry residents from the VA who rotate through our clinics. They come through 5P21 also, my clinic, Northeast Valley, and actually work with us in those spaces, hands-on with the clients. And it's just a rotation as part of their schooling, but we've had success. This is our 4th year doing this program with some of those students who've been through this have pledged they want to work with HIV patients. For me, again, it's a joy, as I mentioned, and a passion. And when I can share that with a young, up-and-coming health professional, I think some of them, they may see the same joy and passion that I see and make that a part of their practice. So programs like this, I think, are a great model that I think even public health could help support, right? As she's saying, even starting at the high school level, a week rotation for high school students. I mean, high school students get, they're protesting climate change all over the world right now, right? Walking out of school. Where's the movement for STD, HIV prevention, which really can affect them now, right? Versus climate change in 20 years, but it's still important, obviously. But I'm saying there are some things being done, there are models out there, and again, as she's saying, that mentorship has to start, and we have to, again, as she's saying, prime the next generation. And I think for African Americans, again, we as people, and I'm not talking to us, we have to have a reckoning about what our real issues are and again, grasp them and not keep our head in the sand and expect someone else to fix it. Thanks.
Can I just add to that, please? Okay. So I was just thinking about that question, and I have 3 millennials that I have raised, and this group of people have no desire to get into the medical field, to be under the constraints of someone that's giving them instructions from 8 to 4:30. They want to do their own thing. They want to create their own businesses. And so we're dealing with a whole different group of people right now. Let me say that I do have a younger cousin who is now a student at USC whose brother in Atlanta is HIV positive, and he is 21 years old. Now, her desire is to go into medicine because what? It has reached her street. So I think what happens is today, because of the generations that we're working with, that is not the interest, but it's something innate. It's something that you have to experience, something that has to have meaning for you. So I don't think that, other than just living our lives and just walking a certain walk, but for me, when I leave here, my desire is to make a major difference in the world, in the community, but it would be focused on something that is solely related to what I choose to do, and I have no type of constraints. You know what I mean by that?
Just real quickly, Jeff. So the average medical student graduates with about $240,000 in debt, right? Right now.
Does the NPH?
Yes.
Who does the NPH?
Yes. So February 7th, John Lewis, in honor of National Black HIV/AIDS Awareness Day, has introduced HR 5806. It's called the HELP Act. It is a loan forgiveness program for dentists, clinicians who want to go into HIV care. So we need to support John Lewis with that. The other thing, I know I may lose some of my lunches now, but the pharma's in back. Well, they used to be back there. Merck was there. V was there. Gilead was there.
They're all there.
Why can't we challenge them to start HIV fellowship programs?
Gilead has one.
But maybe ViiV and other ones, and rotate through our clinics, specifically for African Americans and Latino physicians.
Thank you.
Hello. My name is Louis Smith III. I'm the group facilitator at In the Meantime Men's Group, Inc. And my question is, what are some of the trends that you are seeing among your clients on a day-to-day basis when it pertains to mental health, substance abuse, homelessness, and co-infection? And what are your recommendations for these issues?
Anybody can take it.
Well, I'll go. I mean, obviously, mental health, substance abuse, I'll just take the top two. I mean, huge. And when I speak specifically about my African American patients, there's stigma around mental health too. That's huge in our community. Sometimes it's hard to, there's a lot, I'll put a lot of denial. A lot of people don't want to acknowledge, recognize, and seek treatment when it is there for them. And I think partly because they've had experiences with the mental health system. That's a whole nother discussion, I'm sure, at the HIV Commission about what those resources are in Los Angeles for our clients, and specifically for African American clients. There's very few that I would say focus on them and their specific needs. Because black psychology, black psychiatry is, in my opinion, a different area that needs specific kind of interventions and counseling. So it's a huge need, it's a risk. I feel like I'm the psychiatrist for most of my patients, to be honest, at least from a counseling part, because again, I can relate on that cultural level and identify and speak truth to them without the cloud of potential racism. If I'm telling them they are depressed, it's not just, as she's saying, some doctor who's not of their culture or race telling them, oh, you're just depressed. No, I'm telling them, no, you're depressed. Because, there's a, I think, more, I would say they feel there's more truth. And it's coming from, they may feel trust and they know my concern is genuine and not just academic. So a huge gap. It's a gap in medical care. There's not enough African American health professionals, period, in our country, and definitely in mental health services too. And I know many of us doing HIV care, we are taking home. We are prescribing their antidepressants, anti-anxiety, other medicines, because we have to, because we know what's best for our patients. And we've kind of taken that on as part of their kind of whole patient. Substance abuse, also resources, I think, are maybe getting better. There's some funding now out there. But again, I would say all three of those tie into the housing issues we have too, which I think is bigger than both of those combined. And lack of housing exacerbates all of those things too. So addressing it, I can't just say specifically housing for African Americans, because housing is the issue in Los Angeles. And I think, again, with gentrification in the African American community, it's getting worse, because now you're talking about people who are marginalized with housing, having fewer options, and then being forced to housing that now makes it more difficult for them to operate, just maybe further away, where there's transportation issues that now affect their ability to stay in care, which affects ability to access HIV services, mental health services, substance abuse services. It's just, I can say, just huge conundrum of issues, because you rattled off everything we deal with. All the social determinants are what you're talking about. And how do we chip away at each of those? I mean, I just take each patient and try to deal, if I can stabilize one, almost like whack-a-mole, I can get this one under control, then I'll get this one. If I can get them all together at once, I feel like we've made progress.
You sure? Okay. In the audience.
Thank you. Hi, my name is Adrienne Diagne. Hi, Bridget. I didn't see you for a while since our law conference that I organized. You feel my accent. Discrimination, I know. I'm from Senegal, West Africa, and I work for Doctors Without Borders for 10 years in 22 countries. Nobel Peace Prize. But I'm also a midwife, anesthesiologist, and I'm specialized on HIV/AIDS, reproductive health. I'm the one who started the program, Sexual and Gender-Based Violence, in Tanzania in 2001, with the refugees, Burundian refugees, refugees from Rwanda. I work there in Burundi and Rwanda, and also Congolese, parce que je parle français, pero también hablo español. I speak 7 languages. Yes, I'm proud of it. Black women, power to us. What is important to me is also the fact that In Senegal, HIV/AIDS prevalence was 1%, and we work with all the community is down to 0.5%. But how we do that? Information, education, and communication, but also in first grade, we have a program that I implement in all the countries I work, including Nicaragua and Honduras, talking to our children in first grade. My daughter, who is 17 now, many knows her, I start talking to her about HIV/AIDS at age 5. Today, she's at Hamilton High School, 17, graduating this year. She's an advocate. She's the one who designed this. It's her brand. But I think we need to start by this young generation who knows everything. Yesterday, I said, where are you? Out with my friend. What is it? What are you guys doing? We are cooking. Okay. Then who's the guy? Oh, Mama, you know my friend, the gay guy who's at my school is my friend. Good. We have to be more supportive, and I'm ready, to be honest. After I disappear for a time to raise my daughter, because I'm a single mom, I'm ready to help each and every one of you. Because we can do something if we come together as a team. We need also to support our communities in another way. The doula program, right, sister? Yes, but to help also our people who are in the community, the LGBTQIA community, who need help with their kids, who needs help when they have their new babies, who need their support when they are in certain situations, and also with STDs and STIs. That's why I'm here today. And I can hear the same question when I was here 5 years ago, is the same thing coming back. We need to change. And the change starts by us. Thank you.
Yes. Hello, hi everyone. My name is Markeisha Henderson. I'm a health education specialist. I currently work with LA County Department of Public Health. So I want to thank everyone for sharing their vast experience. And my question is, there's been a lot about how do we mentor people into the medical profession or clinical spaces. But as a MPH, a young black millennial who is 30 plus, I am also unapologetically bringing my efforts to work around black health, black women's health into these spaces. And I agree with your millennial children about not necessarily wanting to be tied down to institutions that don't allow the space to be innovative and to really tackle the issues. And so my question would be, how can you leverage your positions as physicians? I have considered that life and also looked at ways that I can expand in public health. How can we leverage that? What are some strategies you may have or may not have considered to leverage your position to bolster up those who are in the MPH side of it? Because I would say we are very poised, well-poised and positioned to do what you're saying around community organizing, around empowerment, around advocacy, because that's what we go to school for, to do that side. And I know a lot of medical providers then go and get their MPH to get the community-based knowledge, but how do we get to push those black people or black women as myself, come up and coming, to be in leadership positions to help on that side of it, to really support your work?
Thank you. I would say, as Dr. King had mentioned, are there avenues that you can learn how to write grants to get this funding? Okay, so that's what I'm saying, but how do you expand that? And again, it's a mixture of all of us. So someone outside that HIV space and with this long resume, but able to write the grant, and then you partner with us. Say that you have our back and you're a partner, you're an MOU, so that the funders see that you are still connected to those folks, but they're saying that the funding has to go to them. It's going to you with their mentorship. It's a matter of them trusting our experience in this space to help expand it out to other spaces that are going to help deal and address the areas of the epidemic that we can't touch.
Right. Well, I guess my question would be more so like building a stronger partnership in that role. And I've worked with Dr. Curley when I used to be in Boston, and we've had a lot of conversations. So it's not an attack in the sense of how do we advocate for those who are on the medical side to be in the leadership position to partner and counter and support, or I should say complement the work that's happening in the actual medical space.
You know, that's a very interesting question. Leadership is sometimes very difficult to get to, especially if you're a person of color and if you're a woman of color. We talk about glass ceilings, we also talk about the ability to use whatever influence that we possibly can to increase the pipeline. So that's been a challenge for me, and I think a lot of us have come together that are in leadership positions, and we say, how do we do this? And so I think it's going to take a lot more discussion, and I know discussion is something that, you're tired of talking, now you want to walk the walk. But I think we have to crawl with that. I think some of us that are in leadership now that are people of color, we wrestle with, number one, making sure that we maintain. And so making sure that we increase the pipeline is always at the back of my mind. And, I think it's something we just have to come together and talk about and see what we can do to move it forward. Not just keep it talk, but, walk the walk. So it's a challenge. Thank you.
And we have only a couple more minutes, but we have one last question in the back, and then we'll close out.
Hello, my name is Jeremy Dow. I'm a third-year PharmD student at USC School of Pharmacy. And I was wondering about the opportunities and challenges that you see with Senate Bill 159, which now allows pharmacists to furnish PEP and PrEP.
Come on now, you started it. No. Oh, yeah.
So my concern is that the desire to get more people onto PEP and PrEP, I think was overshadowed by, what was overshadowed was the need to train African American community physicians, PAs, to do that work. And I don't think there was enough time and input from physicians into that bill to get that passed. So I'm very concerned because I think what this is going to cause is a multi-tiered delivery of healthcare. That furnishing of those pharmacies for PEP and PrEP, I think will not be within our areas that need it the most. I don't know if anybody else has any comments.
I agree with you on that. And speaking with pharmacists, everything is about the bottom line and how can we increase the bottom line without really looking at the consequences of increasing the bottom line. And so I see that as a challenge, and I hear it as a challenge from pharmacists. You ask, well, where do you refer patients to once you put them on PEP or PrEP? And how do you refer them? What's the policy, the procedure? And I think, everyone's so interested in jumping on the bandwagon really fast that that part really hasn't been thought out. We talk about linkage to care. We talk about the HIV and continuum of care. And I think people, at some point, there are huge gaps in that. And knowledge and education is something that, has been, said to me one-on-one by pharmacists that they're lacking. So I think we're creating, you said this multi-tier system. We are, and then, we can't see into a crystal ball. But if you look backwards, then you can see when you have these gaps, these multi-tiered, you certainly have gaps and disparities increase.
Thank you. So on behalf of the Commission on HIV's Black African American Community Task Force, we would like to thank our panelists for taking time out to be with us today. Please give them a round of applause. We would like to thank the Commission on HIV, the Commission staff for your time and your efforts. Thank you to Jeffrey King for the recommendation of this specific panel presentation for today. And we would like to thank the members of the Black African American Community Task Force for your time, effort, and commitment.
So for those of you who are task force members in the audience, please take a minute to stand and be acknowledged and recognized for your work. Come on now. Task force members, stand, please. Thank you, thank you, thank you. But I got to take a quick minute to thank Dawn. Dawn McClendon, where are you? Where's she at? Don't you hide. Don't you do it. She worked with us tirelessly to get this panel off and seated with success, but like my commendation to you. You are a badass girl. Love it. We'd like to thank everybody for taking the time to have this conversation with us. I know we tipped in and out of some topics today, but we, again, in honor or in commemoration of National Black HIV and AIDS Awareness Day, remember where this epidemic is seated, and remember to acknowledge those who should be driving the boat to get us to the end. We drive the boat, thank you. Good day.
Thank you so much.